The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to today's webinar, Trauma Verification's June Q&A web conference. You've joined the audio of today's event by either dialing into the webinar's conference line or via your computer system's audio. Now, please note that the quality of computer audio can be affected by bandwidth as well as computer speed. So if you have any trouble hearing our speakers, try simply dialing into the conference call by selecting Phone Call in the Audio tab of your control panel, which will be found in the upper right-hand corner of your screen. And then just dial in the number and access code provided there. I would now like to introduce Molly Lozado, Trauma Verification Program Manager.
Thank you. Thank you, everyone, for joining today's webinar. I'm just going to cover some housekeeping things. Today, joining me will be Rachel Sanchez. She's a site visit coordinator for the Trauma Verification Program. Continuing education, to qualify for CE, you must attend at least 15 minutes of educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar, ending with instructions on how to claim CE. If you have any questions during the webinar, please feel free to email us at cltvrc@facs.org. Just going over, again, some housekeeping things. The goal for today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient. Understand the processes and standards involved in an ACS trauma verification site visit and how following these will positively impact the quality of care of the injured patient at your facility. So with that said, let's get started. Just again, for those who are new to our webinar, this is just the copy of the resources manual. If you have a hard copy or a PDF copy, which can be downloaded on the website noted below, please feel free to use that while we go through the presentation. Along with that, you also want to use the clarification document and the change log document. And again, that's available on the resources webpage. And those are updated pretty frequently on a monthly basis. Here are some resources for, again, some of those that are not familiar with our webpage and what we have to offer as far as resources go. There's the recording of all past webinars are listed on a new webpage, as noted here. And the stakeholder public comment website is still open for those of you who still have any thoughts or input regarding the standards. Frequently asked questions, the very limited frequently asked questions, as we will be preparing to launch a new FAQ soon. There are a couple of tutorials, again, for new folks or even for folks who are preparing for a site visit. There is a new webinar that we just launched as well as becoming a verified trauma center site visit. And also there's a new participant hub that it's called the Account Center. So you'll hear that word often, and Rachel is going to go into a little bit more specific detail on updates that we've done to the Account Center and accessing that. All questions are pulled directly from the questions that are submitted. There have been no edits made to the content. If your question is not answered today, the question may require more information, and you will receive a response from ACS within a week after the webinar for follow-up. So with that said, I'm going to go ahead and transfer this to Rachel for scheduling reminders and updates.
Thank you, Molly. Good afternoon, everyone. So just wanted to speak a little bit on the site visit application. And we want to inform everyone that the site visit application is now online only. So there's no more printing out the application or emailing it in to us or faxing it. It's quite simple. It could be accessed on the following ACS trauma website pages. And if you see below, you can access it right on the VRC site visit application page where you normally would have. Or you can also access it at the Trauma Quality Program Participant Hub Account Center. Both of the links will lead you to an Account Center page. You'll see right there that the ACS Trauma website page will link you right to the Account Center page. You'll see the logon link right there. So in order to log on, you'll use your username and password that were emailed to you when you started the process of joining a trauma quality program. So for example, for those who participate in TQIP, this is the same password you would use to access the TQIP education portal. So once you log on to this page, it'll open to the very next, you'll see right there at the next page. This is the first page you'll see. So if you scroll down, you'll see that there is request a site visit, and that's where you would open it up for the site visit application. The application will drop down, and it's a very short and simple application. Right there, it has the instructions on top, and you'll see it'll ask you for the preferred dates. And just as a reminder, the application must still be submitted at least 13 to 14 months in advance of your requested site visit date and before expiration date. You'll also see on the application the alternate pathway there. And as a reminder, an alternate pathway review should definitely be requested on this application for surgeons and physicians who trained overseas and want to participate on the trauma call schedule. Their CVs must be submitted to the COTVRC@FACS.org, as they will be vetted by a subcommittee for eligibility to go through the alternate pathway. And also you'll see right there on the page that the orthopedic trauma liaison, all level 1 trauma centers must also complete the orthopedic trauma liaison, the OTL form, which can be also downloaded on this page. And you could submit the form to the COTVRC@FACS.org email with a copy of the OTL's curriculum vitae. And as a reminder, we're accepting applications for May 2019 and onward. As for the pre-review questionnaire online access, once your application has been submitted, the VRC office will provide you with an email receipt of confirmation. Your logins to the online PRQ will be provided within the confirmation of that receipt email. And the PRQ can be accessed right there at that website. And a copy of the PRQ in Word can also be downloaded from the following website. For the site visit application payment, we ask that you do not submit payment until you receive an invoice. And that you'll usually receive about 30 to 60 days before the site visit. Your center will be billed annually for the trauma quality program fee, and this annual fee will not include any additional visit-related fees, such as for additional reviewers. And you can find the fee structure located at the below website. So scheduling site visits. So visits are being scheduled quarterly. And by the way, just let me step back a little bit. If you emailed us your site visit application and have received an email receipt with your PRQ logins, you're set. You do not need to go in and reapply online. So we have your site visit already in our system. So however, I will be sending you an email soon asking that you provide us with the exact dates you would like to have your site visit. And the visit will occur on your chosen dates, but we may ask for different dates if the review team cannot attend the requested dates. Once the review team has been secured, you'll receive a confirmation email which will include all the reviewers' contact information. And you should get this confirmation email approximately 120 days prior to the scheduled visit. As far as site visit preparation with reviewers, the ACS travel agent will arrange site reviewers' flights. Reviewers will make their travel plans approximately 20 to 30 days prior to the site visit. And the hospital is responsible for arranging and paying for the site reviewers' hotel accommodations as well as their ground transportation. And we also ask that you contact reviewers directly within 30 days of the site visit for their flight itinerary and any other logistical information that may be needed as far as like rides, to the airport, the ground transportation. We definitely want this to be a successful visit for you. So now I'll pass it to Molly.
Thank you, Rachel. We're going to go and we're going to move ahead with announcements. Just for you folks, the next verification Q&R webinar is going to be held July 26th of 2018. The deadline is going to be July 12th of 2018, and it's going to be between 12 and 1 p.m. Central Standard Time. Also, if you have not save the date, the next TQIP conference is going to be November 16th through the 18th in Anaheim, California. So please block the date. And if you have any abstracts, the deadline has been extended through June 30th. Hotel reservations are open now. And there's a listing of pre-conference workshop registration at the link noted below. And again, for some of you who are new to our webinar or new to our processes, there is going to be an optimal course, and the optimal course talks about the verification process and the site visit. So if you're interested in doing that, please go ahead and secure your spot at the pre-conference workshop. So we're going to go with some PRQ updates that we've made. Some of you may be currently working in your PRQs, and if that's the case, we will go ahead and reach out to you guys. But just want to point out that we've updated the Chapter 19 research segment in the PRQ and also in the Word document. And again, this is just for level 1 adult trauma centers and level 1 pediatric trauma centers. So what we've done is we've made it a little bit more cohesive, where it's aligned with the chapter requirements. It was a little confusing in the past, where we're asking for, if you are meeting the 20 research articles, and then it just kind of jumped down to the alternate pathway. So we just kind of aligned it, particular to questions 5A and 5B, where it's asking which of the research methods your trauma center is going to participate in, whether it's the 20 research articles or the alternate pathway. So again, we just kind of aligned it a little better for folks. And also, I just want to mention that the CME for all specialties and appendices, as you know, there's been a wonderful change to that. Programming is taking place to update those questions within the PRQ. You're not going to see them just yet. When those occur, or just about when they're about to occur, we'll let the trauma centers know that are in the process of filling out their PRQ, because what's going to happen is we are going to eliminate or not display those questions. So if you answer them by accident, just answer them as a yes, as we've instructed you to do so. Just the trauma medical director and anyone who's seeking the alternate pathway or has previously been approved are the ones that need to meet the CME requirement. Those areas will remain within the PRQ. So I just wanted to give everyone an update about that. And then a couple of more updates. Research form, because we aligned the Chapter 19 on the PRQ, what we also did is we updated the research form. Again, this is for level 1 trauma centers. So we made the research form as an Excel file, so it would be easier to work in. And what we also did is we added a PubMed ID number field. So if you know what that PubMed field number is, that is of great benefit for us. So you can also use one Excel sheet to document all your research articles, and you can use the sheets noted at the bottom of your Excel. This way you don't have to do one for every single article. You can just do it in one Excel worksheet. And once you are done with that, we are asking trauma centers to forward a copy of the completed Excel worksheet to the VRC office. And what we're doing with that, we are validating that information. That's why we're asking for the PubMed ID number. If you have that, we do know there are some PubMeds that are have been approved. They may not necessarily have a PubMed ID number at this moment. And again, the office is validating that, and what we're doing is we're doing that because we're helping the reviewers out and giving them more time to be present on site and not necessarily have to go through every single document. But if they choose to, that's okay. But we will definitely let them know that we have validated the articles, and if they have any questions, they'll definitely present that to you guys on site. The research form is available on site, the updated research form, so you can download that at your convenience. And again, it's an Excel worksheet, and it's located under the heading Preparing for Your Site Visit. We've done some modifications to our webpage, so I just want to let you know that it's under the subject of Preparing for Your Site Visit, and it's the second bullet down. There was a miscommunication in last month's webinar, and we just want to let everyone know. We did send an email out to all the participants, but we also wanted to bring it back to this presentation. The question that was asked was about the antibiotics. Is there a reference for appropriateness and timing of intravenous antibiotics for all open fractures? And our response stated that the VRC office or the VRC chairs recommended 90 minutes. Actually, that is 60 minutes, and we apologize for that oversight. Another thing that came from the new change in the CME is the CE for the Trauma Program Manager. We did not cover that in last month's webinar. We were still waiting for clarification from the chairs, and we've received that. So for a level 1 and 2 trauma center, adult or pediatric, the Trauma Program Manager must show evidence of educational preparation with the minimum of 12 hours. So that's in sync with the Trauma Medical Director, of trauma-related continuing education per year and clinical experience in the care of injured patients. So this has been added to the clarification document and also the change log, and that did go out this past month. So if anyone was not on that distribution list, please let us know at the cotvRC@facs.org. So we're going to move ahead with general questions. Focus review on site. How do I know what charts to pull for a focus review when the deficiency was PI related? So for a focus review, you will pull the chart categories that reflect the deficiency cited during the initial visit. So if the deficiency was PI related, that is the category the reviewers are going to focus on. So any cases that have to do with PI that went to peer review, those are the cases that you're going to pull on at the time of the focus on-site visit. And the time period will commence from the time the corrective actions were implemented to those standards or that requirement. So if you started that right shortly after the initial site visit, then that's when we're gonna want it from that time period to when you have your actual site visit. Please note that you are going to have far fewer charts than you did at the initial visit. So the initial visit consists basically of 120 cases. This upcoming focus review, you may have only 50 cases. So again, we're only want to focus on the deficiency cited. PI encompasses a lot of areas, so you may have a little bit more cases to pull, but relatively it's going to be a short number that you'll have, and also you may not even have some cases in specific categories, and that's okay. Don't duplicate any charts. We don't want you to duplicate any charts. Just pull what you have at the time of the site visit. Is it ever okay to transfer a non-trauma center within a system if only injury is neuro and the non-trauma center has neuro capability? Without having all the specific details, if the patient was stabilized at your trauma center by the trauma surgeon or neurosurgeon and the decision was made to transfer that patient, the patient must be transferred to a similar or higher level trauma center that is able to provide care for the neurotrauma patient. So if that non-trauma center is able to care for the neuro patient and they have the capabilities, then it is acceptable, and please be sure to document that. Several criteria state that a trauma surgeon caring for pediatric trauma patients in an adult facility needs to be credentialed for pediatrics. Can this be done as a statement that they can provide all credential items on pediatrics, or do they need a separate credentialing packet completed for pediatric patients? What is the best format? Will this be the same for a combined pediatric and adult facility? So my understanding is that this facility has adult and children, and they want to credential their providers for both the adult and pediatric, and that's okay. They can do that. So really the credentialing process is going to vary among all trauma centers. However, if they're going to be credentialed to provide care for both populations, the adult and children, there should be criteria for each of the categories. So if there's adult, there's children, that you want to make sure that whatever your process is, it's one and the same. That's okay as long as you have criteria for both, or in this instance, they're calling it a packet. It could just be one packet. Can you tell me what activation level should be given when an upgrade or downgrade happens, the initial activation or the final activation? If the trauma patient met an upgrade or downgraded activation, ultimately both will need to be documented. You want to make sure you're capturing this. I know in some registries there's not an area to capture the activations, whether it was upgraded or downgraded. So you want to make sure there's somewhere that you're capturing this information. The final activation would be specified in the medical record. In either scenario, as I mentioned, you want to track these instances and review them through your PIPS process to ensure that the activation criteria are appropriate. Again, I don't have all the specifics or the details behind this. So it could also be if the call occurs from the field and it's causing a center to upgrade or downgrade their activation, it may be a matter of educating the EMS personnel of your activation criteria. Furthermore, as I mentioned, these occurrences may impact your under and over triage numbers. So you want to make sure you're documenting all this and you're capturing it and you're reviewing it through your PIPS review. When is the new resources for optimal care of the injured patient anticipated to come out? That's a great question. We are still working through the revision process. We've only completed a handful of chapters and it's still ongoing. So we are anticipating sometime next year. We don't have a date selected or a date that we're going to release this information yet. When will the revised PRQ be available online? If we have information already in the PRQ before the revision, will we have to redo that entry? Absolutely not. We will not ask trauma centers to redo any of the PRQs. If it so happens that you're in the midst of our revision cycle, or once it's been disseminated, or I'm sorry, been published, ideally what's going to occur is that if the book, let's say for example, the book is released in January 2019, we will be giving trauma centers enough lead time where they're not entering data into the old PRQ where we'll need it in the new PRQ. So there is going to be some time in between when the book is released to when we're going to officially start reviewing under the new standards. So I will say, again, we are revising the resources manual, as you know, and in conjunction with that, hand in hand, we are also revamping and developing a new PRQ to coincide with the updates. So for any visits through this year and next year, and probably through the end of 2020, again, 2020 is a little nebulous right now because if the book is released sometime next year, again, we want to give trauma centers enough time, but it's safe to say that through the end of 2020, you continue to use the current PRQ. Do we need to have copies of each ACLS certificate available, or is the information in the PRQ exhibit sufficient? It's safe to say that you would want to have definitely the information on the PRQ and also have the certificates available. What happens during a site visit, for folks that are new to this and are not familiar with this, is that the reviewers will thumb through your your binders, and if they don't see, say, for instance, the ACLS Certificate Center, they're going to ask you for that information. So it could vary between reviewers, but you definitely want to be on the safe side, and you want to enter the data in the PRQ for sure, and you also want to have your certificates available at the time of the site visit. The American Board of Pediatrics, that being Pete's Critical Care, Pete's EM Docs, no longer issues an end date. Instead, it is a continuous cycle. What do we put as the end date on the PRQ? The American Board of Pediatrics website allows you to verify if they are current. So I'm just going to read this, and then I'm going to talk a little bit about this. And I know this is a changing thing that's going on right now, and we're still developing more information on this. The American Board of Surgery and American Board of Pediatrics have transitioned its board policy to a no end date for board certification. That is true. If your center has providers that fall under the new policy, that's probably probably some new grads or those surgeons who are almost at the end of their boards and are about to renew, then what we're asking is to add their most recent expiration date in the PRQ and adding note to their next to their name as or referencing meeting the requirements for MOC or continuous certification. So just a little background on this. So the reason we went with the MOC versus CME is because all the boards, not necessarily just general surgery, we're talking about ortho, emergency medicine, all of them, all the specialty boards have moved to this MOC policy, except that the American Board of Surgery is calling theirs continuous certification. So there's a little difference in what it's being called, but because everyone's moving to this maintenance of certification, at some point in time, all of them are going to move to this continuous cycle, and it is possible that this end date will no longer exist. So in the meantime, if you do have providers that are under the American Board of Surgery or American Board of Surgery itself, or pediatric surgery and general surgery, and they are in the process of the continuous cycle, just let us know in the PRQ by indicating that they're in this continuous certification process. The reviewers are aware of this, and again, as soon as we get more information on how this is going to impact the other boards, we'll let everyone know. For ortho docs, are the PRQ and OPP requirements for just those taking trauma call or for everyone who takes even a minor trauma? So really, the answer to this is for all trauma, regardless if it's minor or major. So when completing the PRQ, you must list all providers who are on the trauma call schedule who see patients with all trauma injuries. So, so if it's minor or critical and they're on the trauma call panel, that's who we want the PRQ to have listed. The OPPE will be performed for all providers on the trauma call by their respective directors or / liaison, such as for orthopedics, it's going to be the orthopedic liaison or director who's going to perform the OPPE for its members on that service. Same would be true for for trauma surgery, neurosurgery, emergency medicine, critical care, etc. Just to clarify, the only patients we need to collect washouts and antibiotic times on our open tibia from blunt mechanism. So there's actually 2 questions about washouts. So I just wanted to make sure I capture that in this the slide presentation. So in Chapter 9, under orthopedic surgery in the PRQ, there are 2 questions regarding washout times and 1 for antibiotics. They're question 15.3, average washout time for open fracture. Question 16 is asking about average time to wash out of open tibial fracture secondary to a blunt mechanism. And question 17 is asking about the first antibiotic administered. Dictated response times. Will reviewers accept physicians' dictated times to meet time requirements for consultations or emergent consultations if the time falls into the 60 to 30-minute time ranges according to our written guidelines for consultations, emergent consultations. Thanks. So I wasn't clear on which consultations this is referencing, so I did not speak to the 60 or 30 minutes. So I'm probably going to assume that this may be for, for the trauma attending for the limited tier, if it's talking about 60 minutes, but it can be also for these specialty consultants as well. If the times are dictated and transcribed into the medical record, that would be acceptable. In previous webinars, it was noted that a physician cannot self-report the time they arrive to the ED for trauma. However, the monitor response time for neurosurgery and ortho can an ER attending note be used if they clearly report what time the neurosurgeon or ortho arrived in the ED at bedside. So again, with the previous slide, self-reporting is acceptable. Following the release of the resources manual, there's been a lot of discussion about self-reporting. It's not ideal, but we will accept it. So the VRC chairs have permitted self-reporting. If it would be ideal to have a scribe, or in this case, an emergency medicine physician to document the neurosurgery orthopedic surgery specialist arrival time. Is it adequate for transfer agreements to have auto-renewal clauses within them? I'm going to assume, and that's why I put this on here, I'm going to assume this means there is no expiration date or that there is a written clause that stipulates auto-renew on the transfer agreement. I'm not really sure how that's written. If either of those cases, if that's correct, it would be acceptable. However, I would advise that the agreements are reviewed periodically for updates because things can change. So you want to make sure that you are reviewing those at least leading up to a site visit. Is there a recommended staffing ratio for trauma programs besides one registrar, 500 to 750 patients per year? Currently, there's only 2 staffing ratios noted in the book, and the one is, again, trauma registry support, and the second is the ICU nurses under CD 1166, where it talks about patient-to-nurse ratio in the ICU must not exceed 2 to 1. Those are the only 2 ratios noted. Again, there's staffing requirements throughout the manual, that need to be in place, like the trauma program manager, injury prevention coordinator. But again, when you're talking about ratios, those are the only 2 areas that speak to specific ratios. Are there any specific certification or education requirements for a designated injury prevention staff member / nurse? We do not have any certification or education requirements for the injury prevention coordinator. Again, that's something that's going to vary among institutions, and we felt, or the folks who wrote the resources manual felt that that would be left for the trauma center to define. DOA, please delineate guidance that signifies the difference in DOA and ED death when a patient arrives with CPR in progress and ED interventions are initiated. Thus, are peripheral IVs and transition to intubate performed in the ED considered an ED death regardless of rhythm. So we get this question quite often, and so does the TQIP webinars. We're asked consistently to define DOA, and that is just something that varies from center to center, and it's also varies based on state regulations. So I will refer you, or the person who submitted this question, to refer to your state Department of Health for guidance on this, because again, VRC and TQIP will not define DOA. We don't define what that means. So we're going to move on to CD related questions. Regarding OPPEs for the subspecialist, the liaison can complete these, correct? How often should the OPPs be completed? So as I mentioned before in a previous slide, the OPPs for the subspecialist will be performed by their respective directors / liaisons. and how often they're going to be done will be determined by the center. The criteria speaks to an annual assessment. However, you know, you can, as a trauma center, you can determine whether this will be something that you'll do quarterly or biannually, especially if you have some review or surgeons rather who are performing, you know, are having challenges with their performance. You can do it on a monthly basis if you want, or quarterly or biannual, as I mentioned, but the criteria speaks to an annual assessment. Do the board eligible emergency medicine physicians continue to need current ACLS, or do they need to just need to have had it once? Did not know with the change in CME requirement if the board eligible emergency medicine physician is now treated the same as a board certified emergency medicine physician. So I'm going to answer this question with that there is no difference on board eligible versus a boarded emergency physician. We didn't treat them any differently. So whether you had someone who was board eligible as well as someone who was boarded in emergency medicine, they both had to have taken ACLS once. There was no difference in that. The only difference comes in when you have physicians who work in the ED who are not boarded in emergency medicine but are boarded in something other like family medicine, internal medicine, pediatrician, etc., who are seeing trauma patients. Those are the folks that need to maintain current ACLS status. Can you share examples of time-critical injuries requiring a 30-minute response by subspecialists? So I provided some examples here. This is not a limited list. You can add more to this, but here's just some examples. This person asked us to provide them. Again, neurosurgery, penetrating injury to the head would alter mental status, TBI with emergent surgical intervention, TBI with emergent EVD monitoring. For orthopedic, it could be fracture with vascular compromise, complex pelvic injuries with limb life threats, multiple open long bone fractures. Again, the list can be endless. The trauma center will define what those critical injuries will be listed for your subspecialist to respond to within 30 minutes. Do you add into your percentages for non-surgical service admission those that have a surgical service consult? The answer is yes. So for the non-surgical services admission table, you do want to account for all patients who were either admitted with a surgical service consult and those that did not. So you want to make sure you're capturing that data correctly. And here's an example of how to capture that data. So this person asked, for our hospital, it seems that internal medicine will admit the patient for the orthopedic service. So this now becomes a non-surgical admit for us. Is this common, and is it okay being that they are all evaluated by the trauma program manager? So I don't want to say it's not acceptable, but that is something that a lot of trauma centers struggle with, that the patient's admitted to internal medicine, or they're admitted to a hospitalist, or they're admitted to another service. Ideally, what you want the patient to be admitted to a surgical service, that being trauma service for the first 24 hours. That way, the trauma service will do a workup on the patient, and they're able to identify any other injuries that may not necessarily be caught if they were admitted to, say, the internal medicine service. So, for example, I use the example of a neurosurgery case where it's a 43-year-old that's fallen from a 10-foot ladder with a small subdural external abrasion and who's diabetic. Again, here's some examples on how to best meet the non-surgical process where it's cleared by the emergency medicine, admitted to medicine. You want to avoid that. And if it happens, you want to review those instances through your PIPS process. The patient's cleared through by the trauma and ED, admitted to medicine hospitals with a neurosurgical consult. That's perfectly acceptable. Admitted to trauma with a neurosurgical consult is best, or admitted trauma first 24 hours, had a tertiary review exam, that's acceptable, transfer to family physician with neurosurgery on consult is best. Again, there's just some examples on how best to categorize your neurosurgical admits. What does the ACS consider an appropriately trained PACU nurses? Does this mean they must have taken TNCC or ATC on? We had several questions. I think I had like maybe 4 questions on this. Second question was, what are the education requirements for PACU nurses? The PRQ asked for ED certification percentages. But what are the expectations? Ideally, if you have nurses working in their respective areas, you want to ensure that there is some kind of training and certification percentages available to them. The requirement we have is that the hospital has to make education available for all their nurses that manage trauma patients or are involved with trauma care. So for the qualification aspect of it, for the PACU nurses or any of the other nurses, ICU, PACU, the ED nurses, trauma, what have you, that will be defined by the individual trauma center on what that is. And that may include specific certification and training for managing those patients in their respective areas. If the nursing certification training percentages are low, meaning if all your PACU nurses just did TNCC and you had, I don't know, X amount of nurses and there was a very low percentage, say 10%, only had TNCC training or ATCN training, what's going to happen is the reviewers may cite that as a weakness. It's not a deficiency, but they'll cite it as a weakness. So you want to pay close attention to what that percentage is, because it may border a weakness, and it's possible that if it is a weakness, then that could be something that then you can use as leverage to get more training for your nurses in their respective areas. CD 1135. I had, again, a couple of questions about this, just asked a little differently. Should radiology notify ED physician or the surgeon with critical findings? Clarification, our trauma team consists of ED attending. If the call goes to the ED, MD, will that suffice the CD? And I believe the following slide is also in regard to this. And again, without having the specific details, for the highest level of activation, critical information deemed to immediately affect patient care must be verbally communicated to the trauma team. If the call goes to the emergency medicine physician, such as in this case, who is on the trauma team, and that information is relayed to the trauma surgeon, that will be acceptable. Again, similar question, need clarification on CD 1135 in our trauma activation policy. The ED attending is part of the trauma team, perfectly acceptable. Currently, our process is when a critical finding is noted, the radiologist usually sends communication to the ED physician. Again, acceptable. And as I stated here, my follow-up question to this would be, if the emergency medicine physician receives the information, is that information related to the trauma surgeon? If it is, then again, that is meeting the requirement. Ultimately, it's the trauma surgeon that must receive the communication. I am seeking clarification on requirements of a level 2 for surgical specialties. Does a level 2 have to have ENT on call? I have a center that I am working with that has a face call panel that is made up of OMF and plastics. They are under the assumption that as long as they have a face call panel, they don't have to have an ENT call. Can you please provide clarification on this for me? So for level 1 and 2 trauma centers, the ability to care for patients with facial trauma is the requirement. The specialties vary by center and may include plastics, OMFS, or ENT, as long as the center can provide a facial trauma call schedule that includes any or all of the specialties that is acceptable. These specialists are not required to be in-house 24/7. However, based on institutional guidelines, the specialist must be available in person at bedside at a predetermined time when the consult is requested. So for this particular center, they're calling it a face face call panel. So if your face call panel, again, that team is going to consist of various specialties, and if they're able to manage the patient, that is acceptable. We are currently in pursuit to be a level 2. Will it be a major criteria deficiency if we do not have ophthalmology on call? We have transfer agreements with our sister facility who does have ophthalmology. So again, if you're in pursuit of being a level 2, CD 1171 has a list of required specialty services that are needed to be in compliance. So if, for example, this trauma center does not have ophthalmology capabilities or someone who can provide ophthalmology capabilities, it is a type 1 critical deficiency, meaning that if you are in pursuit of level 2 and this is one of your deficiencies, this trauma center will not receive a 1-year verification. However, the trauma center will be able to have an rectify this through focus by mail. If, again, this is the only deficiency, and if they're able to rectify this by mail and successfully meet the requirement, then their verification will be extended for 3 years. Again, any type 1s will not grant a trauma center verification. Are ED APPs who evaluate non-activated trauma patients required to take and pass ACLS, or can they audit the course? The emergency medicine APPs, nurse practitioners, physician assistants who may evaluate non-activated trauma patients, such as during the consultation level or through the fast track, they are not required to have ACLS certification. Simply those that are members of the trauma team and are part of the resuscitation efforts are required to have ACLS. As I speak to here, can you define ACLS certification for the surgical PA role in trauma, first to respond to activation? Do these times count for trauma or just the trauma surgeon? So trauma and or emergency medicine, again, APPs and PAs who function as members of the trauma team, caring for trauma activation patients via assessment or interventions must maintain current ACLS status. For the highest level of activation, the APPs and PAs response time cannot count for the trauma surgeon. However, the APPs and PAs time may be documented for the limited tier activation if he has been credentialed to do so. Again, for the highest level of activation, the trauma surgeon time is what's critical, and that's what needs to be documented. For the 15 minutes for level 1 and 2, for 30 minutes for a level 3. At a level 2 trauma center, can the injury prevention outreach coordinator be trauma and stroke coordinator? No. In a level 2 trauma center, the roles of the trauma program manager and the injury prevention coordinator may be shared as long as it does not negatively impact the trauma program's role. So basically, if it's a high-performing level 2 trauma center and your volume is equivalent to that of a level 1, the reviewers will see that based on your PRQ data, and they may recommend that the trauma program manager just solely be the trauma program manager. But if it's a level 2 trauma center that that doesn't have a high volume of trauma patients, then that person definitely can serve as the injury prevention coordinator. What we don't want to see is that that person serving as the stroke or possibly the Children's Verification Trauma Program Manager. Those are separate programs. The trauma program manager has to be dedicated to the trauma program. So just wanted to clarify that. Alcohol screening regarding patients admitted to a non-surgical service and expert to how are patients to be identified for screening. The requirement is for any trauma patient alive and participatory, regardless of activated or non-activated, who meet inclusion criteria with the hospital stay of greater than 24 hours, who are admitted to the hospital and are entered into the registry. So if your patients meet this criteria, then they would definitely require a screening. And again, this includes patients admitted to the orthopedic surgery and neurosurgery services. Another question about alcohol screening. I'm hoping for some further clarification in regards to CD 18.3, universal screening. In the clarification document, as I just read about the criteria for screening expert patients, if the only patients we need to audit for compliance with screening are those who are eligible, by that I mean if the patient is not eligible, for instance, due to altered mental status, and are not able to be participatory their entire hospital stay and are discharged, still not being able to participate, do we automatically exclude those patients because we know they do not meet criteria, or must the nurse have documented they did not attempt the screening due to the altered mental status? In other words, if the patient is altered, can we assume that is why a screen is not done, or must the nurse document screen not done due to patient being altered? I know it's long and winded, but I think this was a great question, and it cannot be assumed. Otherwise, it could potentially contribute to a deficiency for all, because remember, the criteria is for 80% of those patients have to have had a screening. So if this is an altered state, if this patient had an altered mental status, you want to document that. You cannot just assume it. So have the nurse document that the patient had that the patient was not screened due to not eligible or altered mental status. Whatever definition you want to use is acceptable to us, as long as the reviewers are aware that that's what that meant. So we're going to end this on CME, and I just have a couple of questions on CME. For clarification on CME changes, is it just the TMD who needs trauma-specific CME? Do the liaisons see them? Correct. Only the trauma medical directors at level 1, level 2 adult and pediatric trauma centers require external trauma CME. Can you clarify the CME requirement for trauma program managers? Again, that was an update that we just released this past month. The trauma program managers must show evidence of educational preparation with the minimum of 12 hours. So their hours was changed to 12 versus 16, and that could be internal or external CME trauma-related continuing education per year, along with their clinical experience. Can you explain the MOC process for CME? Also, how should we provide documentation in our CME tracking? I gave a little overview of the MOC process earlier. However, at this point in time, we are just asking for you all to document whether or not your providers are currently board certified or board eligible in the PRQ, and that is what's going to satisfy the CME requirement. We're not asking for MOC documentation at this point in time. So it may be something we will ask for later, as the resources manual rolls out. It may be something that we may ask for. And that will conclude our webinar for today. I'd like to thank everyone for your participation.
Indeed, and thank you, Trauma Verification staff, and thanks to everyone for attending today's webinar, Trauma Verification's June Q&A web conference. If you have any other questions, please contact COTVRC at facs.org. Again, that's COTVRC at facs.org. And on behalf of Trauma Verification and our presenters, thank you again for joining us today, and have a wonderful rest of your day.